Good morning, everyone. At the outset, my sincere thanks to Kavita Madam and the entire Pondy team for the invite and the hospitality. So I'm going to talk on malignant glaucoma. This was described by Von Graffi. As we all know, this is a misnomer. So Weiss and Schaffer proposed a favorable term, ciliary glaucoma. In their own words, this is a glaucoma, secondary angular closure, through an operation characterized by continued failure of the anterior chamber to form. So this is so classic of malignant glaucoma. So coming to this is a secondary angle closure glaucoma. The incidence, it's variable, but of the literature reports, it's as high as 4% after any incision surgery for PACG. It's not only after surgery, it has been reported after lasers, variety of lasers, including laser suture lysis, LPI, diode, bleb needling. There are reports of spontaneous malignant glaucoma, but these are old ones. So spontaneous usually does not occur. So the timeline is variable. It is usually during or after surgery. During surgery, the aqueous misdirection that you see is not true malignant glaucoma. That is acute intraoperative Rocard high syndrome. It can happen even months and years later. In the tube versus trial trap study, the risk was 3% in the tube group and 1% in the trap group. So the proposed mechanism is aqueous misdirection. So we have vitreous pressure. So because of that, we have the forward push of the lens iris diaphragm. So that causes angle closure. So obliterates the anterior chamber. And finally, the cornea decompensates. So who is at risk? So post-trap eyes. So pseudo-exfoliation. Anywhere where the lens iris diaphragm is at a compromise. So this is spherophakia. And this is NANOF. This is post-acute attack. You can see the glaucom flecken and the extensive iris atrophies. So coming to the pathomechanism, so pathomechanism is complex. We don't have a clear understanding of the malignant glaucoma yet because of the multiple risk factors that we have. So it is usually characterized by anterior rotation of the ciliary body with a ciliolenticular touch, uveal congestion causing the push of the anterior lens iris diaphragm. So characteristic is the ciliary vitreal block. So there is resistance at the lens capsule zonular level, which causes the aqueous to get directed in a posterior valve-like fashion. We will see later if this is really true. So we have other add-ons also, inflammation of the ciliary body, myotics. That is why we always tend to stop pilocarpine when the patient has malignant glaucoma. So as I told earlier, it's also because of the compromised loose zonules, abnormal choroidal circulation. Some other proposed mechanisms are increased glycosaminoglycans glycans in vitreous that causes more oncotic pressure causing anterior flow. So what triggers malignant glaucoma is the hypotony during surgery. So that is why in TRAP, we are really particular about reducing the duration of hypotony that we have in any penetrating surgery. And critical factor is the decreased anterior haloid permeability. So this is from Harry Quigley's lecture. So abnormal choroidal circulation, so that causes push of the vitreous, so that causes increased pressure. So this causes anterior movement of the lens iris diaphragm. So here in malignant glaucoma, the posterior pressure is more when compared to the anterior pressure. So essentially a push mechanism. So why is it so important? So the classic teaching is aqueous misdirects into the vitreous that causes malignant glaucoma, but that is not true. So remember this picture. So this is the intraocular volume that you have. So the main trigger for malignant glaucoma is the intraoperative hypotony or any hypotony that is resulting in choroidal congestion. So abnormalities in the choroidal circulation that causes vitreous push, that only triggers malignant glaucoma. It is not the classic aqueous misdirection that happens. That is classic teaching. So this triggers the vicious cycle. So we have the transvitreal pressure, which is not equalized by the outflow of the aqueous humor. So the vitreous gel becomes less permeable. So this is the anterior hyaloid phase that becomes very rigid. So we don't know why this happens, but in some patients this happens. So once this is not equalized with aqueous flow, so this is a vicious cycle which just gets propagated on and on. So this is what we used to do. We used to send these malignant glaucoma patients for B scan to look for pockets, but this does not hold true now. So this aqueous is not like it can't get directed into the vitreous because vitreous is a gel. You can't have aqueous pockets in the vitreous. So this is old teaching. So we don't really look for pockets in B scan now. So if you see the paper, this is in 1987. So we don't follow this now. So again, the same thing. Aqueous is not like a hose pipe. You can't have the aqueous directed into the vitreous just like that. So misdirection happens, but again, that is a misnomer. Malignant glaucoma is misnomer. Aqueous misdirection is also a misnomer. So the exact mechanism is not clear. We don't know why it happens, but that is posterior push. So I would suggest everyone to go through this paper. So this is by Harry Quigley on regarding the mechanisms of primary angle closure, especially the malignant glaucoma. It is good if you read the comment in the letter to the editor also. So there will be so much criticism on the proposed mechanism that he has told about the malignant glaucoma, but it is worth reading the letter to the editor also if you want to understand more about malignant glaucoma. So coming to the symptoms and signs, so the classic presentation with pain, redness, photophobia. An important sign not to miss is a myopic shift in diffraction. A patient coming with 6/6, suddenly having a myopic shift, you have to be wary of malignant glaucoma, axial shallowing of anterior chamber. So it's not just peripheral shallowing, it is axial shallowing in a patient with a patent PA. And of course, angles will be closed. IOP, at first, it might not be that high as to the malignant level. So it may increase slowly. We will miss malignant glaucoma, especially in post-rabbis, because if the bleb is functioning, obviously the IOP is not going to be high in the early post-operative period. And again, there is no response to the conventional AGMs. So these are two pictures. One is malignant glaucoma. Can you spot the upper one or the lower one? Yeah. So usually you'll get confused when you have this is also shallow AC, this is also shallow AC, but don't go with only the axial shallowing or the shallow AC. Look at the IOL reflex. So this is actually an FM causing pupillary block. So if at first look, you can get mistaken as malignant glaucoma. So always look at the IOL reflex. If you don't trust your clinical skill, just go for an ASOST or UBM. So just look at the IOL reflex. See how posterior the IOL reflex is. So this is FM. We actually did PA, but this patient did not respond well because of the extensive peripheral anterior signing gain. So this is classic malignant. You can see the entire lens iris diaphragm forward. So this is the same patient, ASOST, just the FM, and this is the IOL reflex. So always look at the IOL reflex if you get confused with the malignant glaucoma. So what you have to do, of course, serials will not be positive, but just to make sure hypotony did not trigger malignant glaucoma, completion sec finish of serials also. So to the classic teaching is first road pupillary block. So if the PA is not there, do a PA, rule out pupillary block. Even if you don't want to do this, so if you're going to start on atropine, doing PA after atropine is slightly difficult. So always do a PA, rule out pupillary block, because some patients, it can be FM pupillary block, it can be because of vitreous causing pupillary block. So always do a PA. If there is PAS, IOP will not respond to all these things. And if you have a view or if fundus can be seen, rule out choroidal detachment and suprachoroidal hemorrhage. If you have axial length, it's always better to rule out NANOF in these patients. And UBM can show anterior ciliary body rotation, but it may not be possible in early post-ops. So the easiest thing to do is an anterior segment ASOST, look at the IOL reflex. So that will help us pick up malignant glaucoma better. So differential diagnosis is pupillary block, choroidal effusion because of inflammatory or hydrostatic causes, and suprachoroidal hemorrhage or any posterior pushing mechanism causing angular closure. So this is pupillary block because of iris Bombay. So this is the same paper which told this is malignant glaucoma having aqueous pocket and vitreous, but we don't follow this. And this is the suprachoroidal hemorrhage. So this is how we go with shallow AC with high AOP. So if there is suspicion of pupillary block, do a PA. So once that is done, then you can go into the differential diagnosis of a choroidal hemorrhage or a malignant glaucoma. So treatment, we start with medical. So you can start a mydriatic cycloplegic. We start atropine. You can even start tropicamide plus as well as atropine also. The concept is you have to tighten the zonular apparatus so that the lens is pulled backward. So this is really critical in phakic eyes. So this basically reduces the aqueous outflow resistance. You can use hyperosmotics to decrease the vitreous hydration. And of course, aqueous suppressants. So to reduce at least the amount of aqueous that is secreted, and of course, steroids. Steroids are really critical to reduce the ciliary body edema and the inflammation. And if the patient is on pilocarpine, stop it. So this is curative in 50% of the patients in 5 days. So this came from a historical paper in 1972 and 87, but this is not really true. So these patients need long-term cycloplegia. Most of them will need surgery. It is rare that some patients will get better only with medical management. But this next two patients that I'm going to show did do well. So this is POD1 after an iris flaw. You can see a good surgical PA. But this patient had malignant glaucoma. So started on steroids and just atropine. You can see the AC deepening. IOP also came down. So the trigger in all these complicated surgeries is the intraoperative hypotony. So when you're doing vitrectomy, may always make sure the eye is not soft. So this is another patient had a complication during phaco. The wound was extended and iris flaw was placed. So again, POD1, so after atropine. So here PA was not done. Actually, there was a small laser PA, which was small. So when you're doing vitrectomy, it is always better to augment the PA and have a large surgical PA. So remember the trigger, hypotony is the one which triggers malignant glaucoma. So lasers, you can try, but so corneal transparency dictates the role of laser. So you can go ahead and affix and pseudofix, but not in phakic patients. You can do a laser PA with anterior hyalotomy and posterior capsulotomy. There is some controversy regarding the role of anterior hyalotomy. Some say only posterior capsulotomy is enough, but it is really difficult to focus on anterior hyalot because you're just going to throw the laser blindly. And there is always the risk of RD after all these lasers. And if the phakic patient, if you are seeing these ciliary process, you can directly do argon lasers to them. In refractory cases, of course, diode is the one which helps. So the primary surgical management is IZHV. You have to do iridectomy, zonulectomy, hyalotomy, and vitrectomy, all through the same locations. You have to make the unicameral. That is what solves the malignant glaucoma. If it is a phakic patient, you have to combine all this with cataract surgery. And the historical Chandler's operation, we don't follow. So that is just Parsman tap and removing the vitreous because there is always risk of vitreous traction. So the primary surgery of choice is IZHV. In pseudophakic eyes, in phakic patient, you have to remove the lens. However clear it is. So this is the algorithm. So phakic patient, try medical management, try lasers. If it's not, try medical management only, not the lasers. If it's not working, IZHV and cataract surgery. So here you can go in a stepwise fashion, but most of them will have resolution only with IZHV. So these are the papers from the LVP, which looked at the treatment outcomes in malignant glaucoma. So here, eyes with shorter axial length and late presentation had high risk of failure. So this is one from SN. So here they compared 3 different surgical techniques and assessed the risk factors of failure. So they had anatomical success of 96% and IOP control on 84% in those eyes which had a unicameral communication. So that is so critical to resolve the IZH, to resolve the malignant glaucoma. So it is important to also consider the fellow eye because this eye is also at same risk for malignant glaucoma. So do a PI and avoid hypotony during surgeries and avoid myotics in the post-operative period. In phakic patient, if you're going to do trap, give atropine. And prophylactic IZHB in these eyes is a controversy. So in very high risk patients, you can consider prophylactic IZHB. So key takeaways, this is an uncommon refractory glaucoma. It is important to catch early to avoid corneal decompensation. So this patient had malignant glaucoma once. So we had sent to retina and they had done only pars plana vitrectomy. So you have to be behind the retina surgeon to do IZHP. So just PPV is not going to solve malignant glaucoma. You have to do you have to make the unicameral. That is only going to solve malignant glaucoma. So this patient also underwent another PPV, but IZHP was not in that thing also. So finally had no PL. So in confusing cases, note the IOL lens position rather than just the central axial shallowing. So strong cycloplegics whenever you're operating on angular closure is be it phakic patient or pseudophakic patient. If you're going to do trap in these high risk eyes with short axial length and all those, better to give atropine. And always take care of the other eye. And the surgery of choice, as reiterated, is IZHV.